First of all, thank you to be invited. I appreciate all the organizing committee. It's a pleasure to be here speaking and learning with you. So I will talk a little bit now about the role of ankle arthroscopy in chronic lateral instability. So a good way to start is with this question: can we get even better with surgical treatment of the chronic lateral ankle instability? Because we are, with the techniques we have, open techniques, we have very good results. We have the Brostrom and anatomical repair, anatomical reconstruction with graft, and non-anatomical reconstruction. Results are already are very good, not so good in the non-anatomical reconstruction, but this is an option in some cases. But why I'm talking about open techniques? Because even in open techniques, we can use the arthroscopy before the open surgery to remove osteophytes, treatment of osteochondral lesions, confirm the precise diagnosis of instability, and a very important thing, in my opinion, exclude an occult chronic syndesmosis lesion. This can change the treatment if we do an open repair and we don't exclude this lesion. We can have a recurrence and bad results. So I always do an arthroscopy, even when I go open for an open surgery. Speaking about the arthroscopic techniques, we have several options. The arthrobrostrom, all inside plus internal brace. And we are having a lot of publication in the last years with different techniques, slightly different procedures and techniques with good results. So how can we choose the best indications? First of all, we need to have in mind that we have a new concept of instability. It's called microinstability. It's based on the work of Jordi Vega. He described an anatomic concept that we have the anterior talofibular ligament is divided into two fascicles. The superior fascicle, which is intra-articular, is relaxed in dorsiflexion, tensed in plantar flexion. In the inferior fascicle, is extra-articular, isometric, and connected with the calcaneofibular ligament. So, microinstability is that patient that have chronic anterolateral pain after a sprain, but he has an stable ankle without other sprains. So, in this patient, the lateral fibulothalocalcaneal ligament is not injured, just the superior fasciculus of the anterior fibulocalcar ligament, which is intra-articular, and the synovial fluid may impair its healing after the injury. Different of the microinstability patients, he have an unstable ankle, multiple sprains, physical examination with robust findings, injured lateral fibulocalcaneal ligament. This is a paper of Jordi Vega that shows 36 patients with chronic anterolateral pain after a sprain. He arthroscoped these patients, and 50% of them have a mass over the lateral recess that could be the cause of the pain. And 66% has the superior fascicle of the anterior talofibular ligament injured. So when we diagnose a microinstability case, we repair it with the all-inside technique. This is the steps. We need to debride the lateral gutter, the footprint of the fascicle of superior fascicle of the anterior fibular ligament, and we pass the suture through the ligament with a suture passer like a scorpion. We drill the tunnel of the anchor. We pass the suture through the ankle and insert the ligament again in his anatomic footprint. There are different types of this lesion. Type 1 is an attenuation with loss of tension of the fascicle. Type 2A, medial partial detachment. Type 2B, proximal partial detachment. Type 3, total detachment. And type 4, with resorption. We can do this technique until the type 3. After it, we can go with arthrobostrom, or we will have probably, we can't repair just the fascicle. We can use the on-site technique in macro instability too, because of the concept, anatomical concept, that the inferior fascicle of the anterior talofibular ligament has a link with the calcaneofibular ligament. In these cases, in some patients with macro instability, we can use the on-site technique, but we need to have a good enough ligament to be grasped, tensioned, and reinserted in the native footprint. Another arthroscopic technique is the arthrobostrom. This technique, we need to draw the safe zone, first of all. Is a zone that stays in superior border of the peroneal tendon, inferior border of the peroneal nerve, and 1.5 centimeter distal of the tip of the fibula. We have the extensor retinaculum. This is the safe zone. Using the normal anteromedial and anterolateral portals, we debride the footprint of the ligament, lateral gutter. We drill the tunnel of the anchor 1 centimeter above the tip of the fibula. We pass the anchor. We use a suture passer, suture lasso, and go inside out in the markers we done before. A wire loop we introduce and grab the suture. And then we pass the other suture. We drill another anchor, another tunnel for the other ankle 1 centimeter superior to the first one. Do the same process, and then a mini incision. With a probe, we grab these sutures subcutaneously, and then we tied it tightly down with the ankle in a slightly eversion and plantar flexion position. So about the results, when comparing the arthroscopic with the open procedures, we have a lot of studies showing that they have good results, even the open and the arthroscopic techniques. This study here is a meta-analysis with 4 studies comparing 207 ankles, A-Office score with significant difference in favor of arthroscopic, Carlson score no significant difference, no difference in complication rates, but just 12 months of follow-up. This other one, we have several scores, and specifically the A-Office and Carlson scores in arthroscopic Boston group were significantly higher than the open group, with 6 months of post-surgery. And this other study shows a better A-Office score with 6 months and 12 months when comparing with the open procedure. No difference in the complications rates. So we can see with the arthroscopic techniques, we have good results, but we have just a short-term follow-up. We need to see how it will go with the pass of the years. So, to take home message, even if you choose an open procedure, start with arthroscopy. I think this is very important to exclude an acute chronic syndesmotic lesion. Microinstability is an anatomical and clinical concept well defined. Our insight can be used to treatment of macro instability if you have a good enough ligament to be grasped, tensioned, and reinserted into the native footprint. Arthroscopic techniques for the treatment of chronic lateral instability are demonstrating comparable and even better results than the open techniques in short-term follow-ups. Thank you.